Thank you, Dr. Alanikov and Sages, and Dr. Kudsi for the opportunity to speak today. Here's my disclosure. So 24/7, 365, we've been talking about that more and more when it comes to robotic surgery. Why? Why should we even care about that? Because acute care and minimally invasive surgery do not need to be mutually exclusive. There are really well-known benefits of minimally invasive surgery that every patient deserves. Patient care does not stop at 3 p.m. and weekends, and going over the benefits of minimally invasive surgeries beyond the scope of this talk, but we all here know about the less pain, less narcotic need, quicker recovery, length of stay is shorter, all of that. So why should somebody coming in at midnight not get the same advantages? Also, to expand the skill set and bring robotics into the toolbox and be part of innovation and education. And again, education should not stop at 3 p.m. or at weekends. There's also the business aspect of it, because we do have to keep the lights on in the hospital, and robotic surgery is expanding. Most hospitals now have a robotic system. It's a $2 million machine that if we do not use, then that $2 million goes to waste. So we do need to increase utilization. But the question is how to? Of course, there's a lot of resistance when it comes to doing 24/7 robotic surgery. My take on this, as I was able to do this at my institution in Texas, it's a 3-step process: adopt, operationalize, and standardize. There's a lot of overlap in these steps. These are not straightforward. However, the first step, adopting the technology, if you're already robotically trained, great, that's the first step. But if you're wanting to be trained, there's a pathway for that as well. First of all, get support. Reach out to other surgeons, maybe at your own hospital, maybe at other hospitals in area and nationally, and your industry partners. And then reach out for training. There's case observation opportunities. These now can also be done virtually. Online training and simulation, dry labs, regional training centers where you can go and build your skill. And then last but not the least, very important part of this is building your team and performing skill drills with them before you start doing the robotic surgery. Because at 2 in the morning, when the team has to do a robotic case, you want to make sure that they are well prepared. In order to operationalize before you do anything, it's important to get institutional support. Talk to your chair, your division chief, OR directors, mentors, peers. Get support and have your people on your side. But I think the most important one, more than any of these people, is the OR nurse manager. The staff has to be on your side. Robotic surgery is truly a team support. And it's important to have them on your side to train all the staff. Start simple. Start with, if you are not already trained, and this is a new beginning, then start with small non-recurrent inguinal hernias, small umbilical hernias, gallbladders. Get comfortable with the technology. Get over the learning curve. Patient safety has to always come first, and then procedural success. Of course, there will be all eyes on you, and hence important that these are done in a safe manner. And once you have gotten over that learning curve, then go to advanced courses and slowly increase your case complexity. You're never alone in any of this. In your first case to your 10th or even your 50th or 100th case, if there's a difficult case and you think you may need help, call for it. Call a proctor who can watch you. I've been lucky to have my mentor come proctor me on several occasions now. Second thing, team building. So I brought this up in the, like I said, there's a lot of overlap. So I brought this in the adoption phase as well. But when you're operationalizing, you got to start with your A team, the best people who are the best at the game. But in order to make it 24/7, the game doesn't stop there, because the same people can show up every time, every weekend. So it's, from there on, it's time to build a new culture. You got to normalize the robot. There's a lot of fear amongst the staff. Somehow we can do laparoscopy in the middle of the night or on a weekend, but people get scared of doing the same with the robot. So it's important to get over the fear factor. And next, very important to standardize then. Once you have been able to successfully get a good thing going, then have a robotics hospital committee, reduce variation and optimize efficiency. I quoted one of my mentors here, Dr. Anthony Petrick, because we have never gotten over the fact that he told us to do everything same way every time. And there's a reason, there's a method to the madness. So, and then once you're standardizing, part of standardization is instruments and accessories. What needs to be open to make it cost effective? There has to be management from teams to the point of where sterile processing happens for the instruments. So the lessons I've learned in my journey and successfully starting a 24/7 acute care program is that you shouldn't be scared. There will be bumps in the road, and it's okay. When you face those bumps, you just gotta stay at it. Overcome the fear. This is not vascular surgery. There are no wires to keep track of, or I should say this is not even rocket science. And this is less about the surgeons, this is more for the nursing staff that can be very afraid of getting the robot going in the late hours of the night or on the weekends. So telling them that it's gonna be okay and supporting them through it. Culture change takes time, and hence persistence, persistence, and persistence. Engage the nurses and techs. I cannot emphasize that enough. The more engaged they are, talk to them about your outcomes. I think the team cares how your patients are doing. The next day, when you are operating with them again, let them know how the patient did the night before that you operated together, so that they have a buy-in as well. The benefits for the acute care surgeon are being established more and more now, because it's, like I previously mentioned, this is not, robotic surgery should not be confined for just certain patient population who can benefit from this. I think the acute care patients that present with acute inguinal hernias, acute gallbladders, there's not just that, but even some cases of bowel obstruction where extensive lysis of adhesions has been shown to be beneficial. So with that, I want to share a picture of my team. I'm not in this picture because there's no I in team, but I was taking the picture. This is actually us doing surgery on the weekend. I think one thing that I didn't mention earlier is anesthesia. Anesthesia has to be part in the game as well. I have, initially when I started, they thought that any robotic case, even if it's an inguinal hernia, should have an A-line, because there was a lot of fear that, oh, it's the robot, it's gonna take very long, and probably if there's a problem during the case, we wouldn't be able to reach the patient, and because the robot is covering them. But over time, as they'll see your outcomes, as they become your partners, they will understand, and the workflow will improve. Thank you so much.